is to bring in more awareness and work in collaboration with urologist and colorectal team and form a multidisciplinary team so that these patients do not end up having multiple surgeries and we provide them a good quality of life as well as reproductive outcomes. So let's start with the first session where we are going to talk about a perspective like what a gynecologist think about endometriosis or how we manage it, and when the patient goes to a urologist, how they approach to the patient, and when we work together, what are the outcomes. So Dr. Shweta, can you invite the chairpersons, please?
Thank you. I would like to invite Dr. Ravi Kumar, who is a consultant urologist at Ramya Pramila. Yes. And he's also the HOD of urology at the Max Cure hospitals. So, please come up. Yes. And I would like to call upon Dr. Jayaram Reddy, sir. Sir has worked as a professor and HOD at the urology in Usmania General Hospital and has also established the Uro group practice in Hyderabad. Sir, he has not. He's on. So sir will be joining us soon, and I would like to call Dr. Jyotsna, who is a consultant obstetrician and gynecologist at Ankura Hospitals, Hyderabad. Please come on to the rise. Yeah. So we'll be moving on to our first session, which is about the urinary tract endometriosis, what a urologist should know from the gynecological perspective. So I would like to call Dr. Vimee Bindra onto this.
Gets encased in that and leads to hydroureter and hydronephrosis. Now coming to the urinary tract, the bladder is most commonly involved in 85% of the cases. Then comes the ureter, which is involved in 10% of the cases, kidney 3% and urethra 2%. So we are going to focus more on the bladder and ureter, which is the majority. Now this is our own data, how patients have presented to us along with the dysmenorrhea. The different presentations, they present to us with dyspareunia, painful bowel movements, painful urination in around 12.3% of cases, and they also complain of increased urinary frequency in around 10.4% of the cases. The bladder deep endometriosis is defined by the presence of endometriotic tissue invading the detrusor muscle of the bladder. It can be partial or full thickness. Common locations are the dome. Usually the abdominal part of the bladder is not involved. The extra abdominal part is usually spared. This part is usually spared, and this bladder base and the dome is usually demarcated by the utrovesical junction. Now the partial thickness and the full thickness nodules, usually we may miss on cystoscopy if it is a partial thickness nodule. So if you do a cystoscopy of a partial thickness nodule, you will not see it cystoscopically. So you have to have a good imaging to know about these lesions and excise them. What are the symptoms with which patients present to us? They can be completely asymptomatic and incidentally diagnosed. They may complain of dysuria, urinary frequency, hematuria, recurrent urinary tract infection, atypically urinary incontinence also, and incidental diagnosis during cystoscopy or other intra-abdominal procedures. The differential diagnosis is intraluminal lesions like papillomas, urinary tract infection, interstitial cystitis, and urinary tract calculus. Imaging is very, very, very important in endometriosis, because when we take the patient for surgery, because this is an iceberg phenomena and most of these cases have frozen pelvis, we cannot see through the tissue. So until unless we have a good mapping of the pre-operative disease, it is very difficult to plan your surgery properly. And this is the most common reason these patients land up with multiple incomplete surgeries. So this first line imaging is ultrasound. Dynamic scanning and use of IDEA protocol with mapping of DIE as per #NCN. This is the latest classification for endometriosis. Transabdominal ultrasound is important for renal assessment. By placing the transvaginal probe in the antevaginal fornix, visualizing the mucosa and muscularis for focal thickening and for hypoechoic linear or nodular lesions by gentle movements, these can be elicited. And measurement in 3 orthogonal planes is very, very important. Partial filled bladder is important when you do your own scans. If the bladder is empty, you won't be able to localize the ureters. If the bladder is extremely full, then also you can't localize the ureters. So partially full bladder is the prerequisite. If you want to localize the bladder, you can use your Doppler and localize these jets very easily, and you can measure the distance also from the nodule. So imaging report should mention about the specific location of the lesion, measure the distance between the lesion and the ureteral orifices, which helps us in surgical planning, distance from the vesico-ureteral junction, and if there is concomitant ureteral involvement also. So if distance between the edge of the endometriotic lesion and the interureteric edge ridge is less than 2 cm, ureteroneocystostomy may be needed, which reduces the risk of ureteral obstruction and fistula formation. So this is very important. When we image the bladder nodule, we also measure the distance from the interureteric ridges. Now, when I talk about the partial involvement, so it may not involve the detrusor always, it may be just a superficial peritoneal disease as well. So in these cases also, excision, ablation we don't do. You should not keep on burning these spots. It does not help. Patient may have a symptomatic relief for some time, but they usually come back after some time. So complete excision of that peritoneum is important. Upper abdominal survey is important in these patients. You can see a small superficial diaphragmatic spot as well. So they may have a full thickness diaphragmatic endometriosis also. So this is very important whenever you go inside the abdomen. Complete abdominal survey, abdominal pelvic survey should be done to rule out lesions at different places because imaging cannot pick up these lesions. And then excising the complete peritoneum. This is basically called as anterior peritonectomy, which we usually don't routinely perform unless lesions are there, because posterior peritonectomy is a very common procedure in our endometriosis excision patients. So in these cases, usually there is no breach of continuity or no cystostomy, and this can be easily removed. And when there is a full thickness bladder nodule, you have to do a partial cystectomy and repair. And usually cystoscopy we do. We do not do stenting for all cases. If really needed or the distance between the nodule and the ureteric orifice is less, then we do stenting. Like this case, we didn't have to do the stenting. And you can see just a bleb is seen on cystoscopy, not a full-fledged bluish lesion, which we usually see in cystoscopic image of endometriosis is not seen. So this can be easily missed. If patient presents with a bladder symptoms and you do only cystoscopy, you may tell her that you don't have anything if we don't have a good imaging report or we don't do laparoscopy. Honestly speaking, this nodule was missed in imaging and she was planned for histolaparoscopy for infertility, but then patient had symptoms and we had counseled her completely that whatever lesions are there, we are going to remove. And we found a full thickness bladder nodule and we separated the nodule. It was completely excised, single layer closure was done, and patient is doing pretty well. Most of the time, the gynecologists, usually they are scared to touch bladder and ureters. I think this is the teaching from the medical colleges which needs to change. We were always taught not to touch the bladder and ureter. But we were never taught that you can safely lateralize them, you can safely move it down, and you can manage these diseases better. So this was the nodule which in cystoscopy you were seeing a very small vesicle-like thing. And this was closed with a V-lock suture in a single layer. And the water leak test was negative. Usually after 7 to 10 days, we'll do a cystogram, and if we are confident, we remove the Foley's catheter for these patients. This is a cystogram 10 days post-operatively. Now, surgical treatment with complete excision of bladder endometriosis was shown to improve complaints of urinary symptoms in patients with bladder endometriosis. Now, we are moving to the ureteral endometriosis because we deal with the ureter in almost every case of endometriosis. Bladder endometriosis, although the incidence is common, like 85% of the urinary tract endometriosis is bladder endometriosis, but ureterolysis is the most common procedure which we do in almost all cases because uterosacral nodules are involved. So handling the ureters is very, very important, and how to handle them, we all should learn and do it. So it is 10% of the urinary tract endometriosis, 0.1 to 1% of endometriosis cases. 3 to 4 centimeters superior to vesico-ureteric junction is the most common site of ureteral involvement. Usually it is unilateral and mostly left ureter is involved. It is bilateral in 10 to 20%, extrinsic in 60 to 70%, and intrinsic in 30 to 40%. 50% of reported cases have renal loss. Parametrial nodules also cause encasement of ureter, resulting in hydronephrosis, and renal function test should be done. So this is B, what I was talking about. It is a part of the #NZN classification, which tells us about the uterosacral and the parametrial involvement. And this is how the nodule usually goes over the ureter and compresses it and causes the hydroureter. And this is how it happens. It's very common in all endometriosis cases where this encasement can happen, and most of the cases it is missed also. The symptoms, most of these patients are asymptomatic, non-specific symptoms. Symptoms of DIE, they present to us like dysmenorrhea, pelvic pain, fatigue, bloating, GI symptoms. They may have dysuria, dyspareunia. Sometimes they complain of flank pain. but that also is very late symptom and gross hematuria in some of the cases. Tracing the ureters is very important because in transvaginal scan, the lower third of the ureters can be traced, but for the upper part of the ureters, we need a transabdominal scan. So all endometriosis patients, tracing the ureters is very important. In this image, you can see a dilated ureter very clearly. Assessment of kidneys. So if you are asking for a scan for a patient of endometriosis, do ask for an abdominal scan as well, so that at least any gross hydronephrosis can be picked up. And if they have hydroureteronephrosis, DTPA renal scan for residual renal function to determine what procedure we are going to do and counseling of the patient. Now, surgery for endometriosis, we have to see the outcomes, the risk and complications involved. And then these all are guided by preoperative imaging, which helps us in preoperative counseling and better management of our patients. Now, as I said, ureterolysis is the most important procedure which we have to do in almost all the cases. As we entered the pelvis, we usually do the sigmoid mobilization followed by the ureterolysis, and then we go to the rectovaginal space and start dissecting the other nodules and remove them. So ureterolysis till the ureteric tunnel may be needed in many of these cases where big uterosacral nodules are there. So this patient had a big uterosacral nodule along with the rectovaginal nodule. Although she did not have any significant hydroureteronephrosis on imaging, but if we leave these nodules, as this is a progressive disease, she will develop compression of the ureters and she may land up with the ureteric complications. So these things are very important that when we address deep endometriosis patients, we try to find proper location of the nodules and we remove them properly. So this was a nodule completely extending up to the vagina and we did a robotic surgery for her. Patient had severe pain. Patient had pain during urination as well, although no bladder nodules, no hydroureteronephrosis, but she had urinary symptoms. She had severe dyspareunia. She had difficulty sitting as well because of this nodule. So this is our data where we had mapped all the lesions on surgery as per #NZN. And in this, the B component, the uterosacral nodules, was involved in 68.8% of the cases. So all these deep endometriosis patients need ureterolysis and excision of these nodules. Silent loss of kidney secondary to ureteral endometriosis has been reported several times in literature. Hydronephrosis as a symptom of clinically silent ureteral endometriosis. Most of the cases, these diseases absolutely silent and we don't even get a hint of it. It can cause a complete silent loss of renal function. Routine ultrasound scanning examination of the upper tract in all patients with diagnosed endometriosis could prevent this severe complication. Ureteral endometriosis is rare but can be complicated by potential loss of renal function. Clinical suspicion and preoperative assessment may help with diagnosis and allows for a multidisciplinary pre-consultation. So in a nutshell, how we manage a bladder and ureteral endometriosis, I'll just brief it. So bladder endometriosis, if they are asymptomatic, no involvement of ureters, we can have an expectant management with interval growth monitoring of the nodule. Or if there is a ureteral involvement, it's a surgical management. If she is symptomatic, no ureteral involvement, medical management can be tried with interval monitoring. If no symptomatic relief, then surgical. But if there is any ureteral involvement or hydronephrosis, there is no compromise and it is a surgical treatment for these patients. If there is a ureteral endometriosis, our aim of surgery is to relieve obstruction, prevent recurrence, and avoid obstruction. Surgical approach depends on the location of DE, previous ureteral surgery, extrinsic or intrinsic, extent of ureter involved, and residual renal function. So ureterolysis, as I said, is the most common procedure. Ureterectomy with end-to-end anastomosis is hardly required because it involves the lower third of the ureter in most of the cases, not the middle or the upper third. Ureteroneocystostomy may be required for intrinsic nodules or if there is a stricture where we cannot manage it, and nephrourectomy if the residual renal function is less than 10%. So take-home message is deep endometriosis of the bladder and ureters can be visualized on either advanced transvaginal scan or MRI. Gynecologists with expertise in surgical treatment of endometriosis are indispensable for these complex cases. The treatment approach should be guided by expert ultrasound, MRI, and surgical expertise of a urologist. Surgical complications can be mitigated by an earlier recognition of urinary tract symptoms, non-invasive imaging, and a collaboration between gynecologists and urologists. Urinary tract endometriosis inadvertently encountered at surgery may be best left untreated until proper evaluation, interdisciplinary discussion, and informed consent with the patient occurs. Formalized multidisciplinary team preoperative diagnosis and surgical treatment in an endometriosis referral center led by a gynecologist with subspecialty training in clinical and surgical management is necessary to have optimal and good outcomes for the patients. So most common natural predator to ureter is the gynecologist. This is a slide from one of my colleagues. And do you really think so? So most common natural predator to ureter is not the gynecologist, but it's the endometriosis. And you better believe it. Thank you.
Okay. What you didn't introduce, she is Dr. Vimee Bindra, our gynecologist and the main person behind all the endometriosis work that is done. सब लोग जानते हैं मोदी जी को आपके जैसा, लेकिन फिर भी इंट्रोड्यूस करना पड़ता है. Yes. Okay, so it was good. I didn't see her presentation because I didn't want to be influenced by what I see. So anyway, I'm going to present. I'm Dr. Sanjai Addla. I'll introduce myself. And I'm going to present a urologist perspective of the same problem that Dr. Vimee has spoken about. There will be a bit of an overlap, but I'll try to clarify the doubts that I as a urologist have. So hopefully that helps in clarifying to the other people as well. So just before I go further into, I've got few slides about introducing myself, just to say that I'm qualified enough to be doing what I'm doing. So I did my MBBS from Usmania, then did my surgical training, all of it in UK, and I did an MD in isolation and characterization of stem cells, just giving me a bit more basic understanding of cancer management. Then I did lab fellowship, then a uro-oncology fellowship. And before I came to India, I was a head of department and head of oncology in UK. I was there for 6 years as a consultant. And since August 2016, I have been working in Apollo hospitals as a consultant in Apollo Cancer Institutes. I'm loud enough, I think. Am I loud enough? Huh? Okay, for the online people. Now I think I'll wake up everyone. So I'm an intuitive recognized mentor. The reason why I got involved with endometriosis because I was pushing and nudging Vimee into doing robotic surgery. I mentored her for the initial robotic part of her journey. Now she mentors me how not to do it properly. And I'm involved in doing research. I used to do quite a bit of basic science research when I was there, and I continue to do the same here. And when I was doing my basic science research, I used to keep getting those European Urology Awards. And I was invited to the British House of Commons for discussion on access to robotic surgery. That was just before I came down to India. The reason why I'm mentioning this is just to show you what is my understanding prior to 2018 when I got involved with endometriosis. So I used to think all these things. Endometriosis is rare. Endometriosis is a female version of prostatitis. Bladder endometriosis, just do a TUR. That should be fine enough. Hydronephrosis, stent and give them LHRH agonists. That should address the problem. And extensive conservative treatment and only desperate surgery is what is required in rare cases. That's what I used to think. And in that order, majority of them were nuts. Give them psychological counseling, medical treatment, surgical intervention as the last option. This is what I used to think prior to 2018. Let's see if I have changed. Now we are into 2023. So this is a process of, especially for the juniors, there are things that are unknown to known. So the process of learning, if you were going to listen to Donald Rumsfeld, is there are unknown unknowns in that you don't know what you don't know. So I didn't know anything about endometriosis, and I didn't know that I didn't know anything about endometriosis. So that is unknown unknowns. From there, you learn a bit, which is where I am now. I know what I don't know. So there are known unknowns. Okay? And Dr. Vimee is known knowns in that she knows what is need to be known about endometriosis. Okay? So I'm in the, so first stage is you need to realize what you don't know. Then you can read about it. So as a part of preparation for this, I did need to read about it. So that's why I said I'm in the middle part. I know what I don't know. So answering the first question, endometriosis is a rare urological problem. Actually, it isn't. And Vimee has already mentioned, it seems to, I was staggered by the numbers. 5 to 15% of fertile women or premenopausal women tend to be struggling at some point with endometriosis. That is millions and millions of people. They're suffering, whether they're seeking help, that's different. And when you look at the infertile woman, it almost goes up to 50% of infertile women seem to have a problem of endometriosis. Coming to the urinary tract endometriosis, it is small percentage, 0.3 to 12% of the people who have got endometriosis. So the numbers are small, okay? And as Vimee said, commonest is the bladder. What she didn't define, which I had to read, was what is DI, that is deep infiltrative endometriosis. Whenever the level of infiltration is more than 5 millimeters thick, that's when she kept on using the word DI without defining it for urologists what DI is. I didn't know. So deep infiltrative endometriosis is more than 5 millimeters of infiltration. And when you see in those patients, 50% of them tend to have a urinary tract involvement. So the people who do end up on the surgical table, almost 50% of them do tend to have some urological problems. And the median age, the fertile age, 28 years. So that's why it is a concern. That's why it is a social problem. That's why it's a medical problem. So answering my first thing, urological endometriosis is rare, probably, but it is a significant enough problem for us to be aware of. Symptomatology of bladder is almost the common thing that we see in urology. They have all this. This could be a UTI, this could be a bladder calculus, this could be a bladder cancer. So all the symptoms of something happening in the bladder is what an endometriosis patient presents with. And repeated UTI, commonly we tend to see it. And the thing I wanted you to notice, though we keep on saying hematuria when they are on periods, it's only seen in 20% of the women. If we just use that as the criteria, we miss 80% of endometriosis afflicting the bladder. Cause of endometriosis, the reason why I've included this one is my understanding was that endometriosis is a contiguous thing in that it leaks out, then there should be some nodule there, then there should be a nodule. But there is mediastinal, there is lung endometriosis, totally discontinuous. It doesn't need to be a continuous path. If there is nothing in the pelvis, doesn't mean that there won't be something on the diaphragm. That's why, as we mentioned, you have to be doing a full laparoscopy just to make sure that you have seen all the areas. So this is a bit of a theory, but these are the ones that we think of. Embryonic one. These are areas where normally they're not exposed to the, like you would think that it has seeped into the, because the commonest one is this one, retrograde migration or the reflux theory. Common to understand. The endometrium has transferred through the fallopian tubes into the peritoneal cavity, and that's what seedling has done. That's what you would think. But there are certain areas which are not accessible. Something on the diaphragm. How would endometriosis tissue go up to there? And that's what makes you think that it is something more than that. And the common one currently seems to be the transplantation theory, in that it spreads via the lymphatics, via the hematogenous, and then goes and infiltrates. So it is almost all the features of malignancy are there. That's why they are trying to use chemotherapy drugs in trying to treat endometriosis, because all the features of neovascularization is there, pain because there is new nerve supply is there, and lymphatics are there. So all the three features of malignancy are there. That's why I think the transplantation theory is much more appropriate to The ideal, we don't know what actually it is, but these are the common ones that we tend to. Iatrogenic one, following a cesarean section or something wherein there is an injury to the peritoneum lining the bladder, that's when it seems to be the implantation. But these are the four. One, the easiest one to understand is the retrograde one, but probably the most plausible one is the transplantation theory. That explains my earlier preconception that it has to be a contiguous one. It doesn't need to be contiguous one. It is lymphatic, it is hematogenous, it will go and spread anywhere it wants. Endometriosis in female is a version of prostatitis in men. Prostatitis is 10% of my British patients used to have prostatitis, which is they have pain in the pelvis, no cause found. That is prostatitis for us. So a female comes there, sits, and then complains of pain in the abdomen. That's what we thought. But when you this one, it seems to be this one quite a good paper wherein they looked at the impact on their quality of life, and what they found is these. 50 to 70% of pelvic inflammatory disease patients seem to have endometriosis. The corollary is not true. Patients who have got endometriosis don't have PID, but the ones who have PID do tend to have endometriosis. And there is a 3 to 4 risk of increase of endometriosis. So whether we were diagnosing these patients as PID before, now we have got a bit more understanding, that's why we are diagnosing them as endometriosis. But one thing for sure, it is not the female version of prostatitis. There does seem to be a problem, and we don't do radical prostatectomy for prostatitis, but we can do excision in case of endometriosis. This one, deep infiltrative endometriosis and the Enzian classification. I had to read it because she keeps on mentioning it and I never knew what it was. So I thought I would highlight what I learned. So there are the 3 parts to it. The first one is the rectovaginal space, less than 1 centimeter, 1 to 3 centimeter, more than 3 centimeters. All of them have got more than 5 millimeters of infiltration. So that is the A. B is the sacro-uterine ligament. Posterior, the cardinal ligament, where it tends to trap the ureters. The third one is the rectal involvement. All of them the same, 1 to 3 centimeters, more than 3 centimeters. And these are either, if you say far or foreign, they are not in contiguous areas. So either the bladder is involved, or intestines are involved, or ureter are involved. And again, they go by the same. U1, U2, U3, less than 1 centimeter, 1 to 3 centimeters, and more than 3 centimeters. And then you write the overall score at the bottom. Okay, so whenever someone mentions about Enzian classification, this is what it is, and those are the 3. She will make modifications of this one, the Vimee Bindra modification of the Enzian classification.
This is a modification from George Kexton only. It's a hashtag Enzian, which is latest one, and it has been introduced in January 2021. Now this is from 2012. So in this, peritoneal, ovarian and tubal component were not there. So now in the newer one, we have peritoneal, ovarian and tubal component along with all the far locations as well.
It wasn't fitting on the one slide and it was confusing me. So I thought if it was in front of me and it was confusing me, I thought I will give you a view of what actually Enzian classification means. Thank you, Vimee. So bladder endometriosis. As I said, I've been a consultant since 2007. Whenever we saw it, we said we'll just do a transurethral resection of this one and then that should be it. But we didn't understand the rationale. It is coming from the peritoneal surface into the urothelial surface. It didn't start from the urothelial surface going out. Urothelial cancers start from the urothelial surface and go out. So you can do a TUR for them, not for these. So commonly affects, it has already been there. Symptoms are premenstrual generally, and hematuria is only seen in 20%. And the most important one, ultrasound scan is superior to cystoscopy in diagnosing them, staging them, and quantifying them. So though we say cystoscopy is normal, it's normal because it hasn't yet come up to the mucosal level. It is still in the muscle level, probably is submucosal. Okay, so whenever you suspect that the patient has got symptoms of endometriosis, cystoscopy is normal. That doesn't rule out endometriosis. You still have to do a good transvaginal ultrasound scan or an MRI scan. TUR can be done for biopsy just to make sure that there isn't any cancer, but that isn't the treatment. Medical treatment on very small lesions, 5 millimeter lesions, perimenopausal medical treatment in the form of LHRH agonist would work, but 50% of dye would not respond to LHI. So when we are talking of a proper infiltration into the bladder wall, the symptoms might settle for a period, but they will recur. So these need excision. Quite often, these are on the peritoneal surface. So you don't need to do a partial cystectomy. You just excise the surface of them. That should do the job. You always don't need to do a partial cystectomy, but complete excision is necessary. Hydronephrosis, many years we just stented them and then gave them LHRH agonist. Does that work? It is in the left lower ureter, the commonest one. Bilateral is there in around 20%. And if you see, commonly it's an extrinsic compression. It can be intrinsic as well. And I found that intrinsic quite difficult to understand. So these are outs, it has inside out. It's almost like a urothelial cancer growing out. There isn't that much of compression outside. So commonest one is extrinsic, but it could be intrinsic as well. And for intrinsic, they're more difficult to treat. You have to excise them for us to address them. You have to do a ureteroscopy to make sure that it's not a urothelial cancer, but the only treatment for them, you can try medical treatment, but generally that doesn't work. It does involve excision of them. Again, they did histology to see whether it is fibrosis, the scarring that is causing the hydronephrosis, or the endometriotic component that is causing it. And commonly it is the endometriotic component that is causing the hydronephrosis. So if you just think scarring and put a stent there, that doesn't tend to work. So MRI is better for quantifying this, and only 40% of the ureteric dye is symptomatic. So it has to be picked up on imaging. Whenever someone has got an endometrioma, you have to look at the upper tract to make sure that they are normal. Treatment-wise, LHRH agonists decrease the amount of bulk of it, but it doesn't unobstruct them. So you have to, if there is an obstruction, you have to end up excising at the extrinsic component or ureteric reimplantation if it is there. If you just do medical treatment, a third of them tend to relapse. Ureterolysis works for small one, which are less than 3 centimeters in size, but anything more than that, you have to excise. And in this order, probably they need them, but probably not in that order. Each patient has to be assessed and then offered whatever is the appropriate treatment. And I'm going to summarize it with this one. Endometriosis is a multifaceted problem, and it says modern treatment of endometriosis should be personalized, and depending on where the problem is, whether we involve Kishore Alapati, the colorectal surgeon, or Dr. Vimee Bindra, or myself, depends on what is the component that is involved. And where am I now? This is my current state. Thank you very much. Any questions? All of them directed to me. Thank you, sir.
Even as you think, I also used to think endometriosis is not our problem. But since I'm associated with a gynecologist, I used to be called in between. So it's really a deadly disease when you see. I'm not a laparoscopic surgeon, but I used to do open procedures. When I call it's a locally advancing cancer like that. So most of the time, I used to do the ureterolysis, but those days I used to do only by open. Now some laparoscopic surgeon is doing. But in isolated cases of bladder endometriosis I have seen, they present with hematuria more during menstrual periods. And do a cystoscopy, the lesion will be so terrifying, angry looking, you don't feel like doing biopsy. So I have done few cases to open excision of that tumor without biopsy. So they proved to be endometriosis. And as you said, this is a multifaceted approach should be there. It's not a purely gynecologist or a urologist. As surgical gastro or colorectal surgeon is also important because most of the time it is a rectovaginal space that is involved. Yeah, that's mainly our ureters. Any questions? Now the speakers will take.
When you strain the ureter, in fact, you can't even look properly sometimes. That is ureterolite is difficult to look at.
So, preferably, I always feel that the risk of injury of the ureter is a lot more than you do preoperative stenting. Just because you think that you are not going to injure, and you injure it more. So you can have a ureteric catheter just so that you know where it is, but I won't dissect on top of it. And it doesn't move. There is too much of memory in any of the tubes, so it doesn't move away for you. Ram Reddy sir, anything? Ram Reddy sir is head of urology in NIMS. Do you see, do they come up to semi-government institutions?
I rarely see endometriosis in NIMS. Even Murthy sir before me, he was head of the department. Maybe that may be the reason, or no one refers to us. So I do only open surgeries. I don't do laparoscopy or robotic surgeries. But even in open surgeries also, we rarely see because our workload is too much, but still we don't see so as common as you have told.
Shall we just start the case-based discussion, finish in half an hour? Yeah.
Dr. Sanjai,
Yes.
I just wanted to add.
Oh, sorry, ma'am.
Hi, I'm Dr. Jyotsna. Hi. So, endometriosis is quite a relentless disease. It's not like you saw one nodule in the bladder, you resected, and your job is done. So, I mean, we are going to see that patient again and again. Is there anything that you would like the gynecologist to know if you've resected a bladder nodule in taking care of the bladder, as well as monitoring her for any further symptoms?
So for me, as I said, the
involvement.
reason why I introduced myself for so long was just to say that I'm a cancer surgeon. So the problem with cancer surgery was whenever you knew a tumor was reaching an organ, you didn't resect that organ because the patient would end up needing radiotherapy anyway, because the margins would come positive. Whereas here, if you get a bit of a clearance, then symptomatology wise, at least we are treating the patient. So that's the first aspect. But the biology is, I think there has to be developments in the understanding the bio, because still we have got 4 theories of how it happens. Yes. And when they do the histological analysis, everything that is associated with cancer is there. For me, when I was reading it, I think there might be some eureka moment, like when I was a house surgeon, the commonest operation was vagotomy and GJ. We used to do 4 or 5 of them in a day. Now no one has it, because somebody took a genius to say actually it's an infection. Yes. So I think somewhere along we'll understand the biology a bit better, then we'll be able to address the biology rather than the anatomical features that we are operating as surgeons.
That's true. Thank you so much.
Thank you.
Thank you, sir. Yes. Yeah. So now moving on to the panel discussion, I would like to call upon our experts, Dr. Murthy, sir. So, sir has been the professor and HOD of the Department of Urology in Kamineni Institute. Sir, Murthy, sir, please. Yes. Yes. And I would also like to call upon Dr. Balama, ma'am. Please, ma'am. She is the consultant at Shalini Hospitals, Barkatpura, and she is the chairperson for the governing body, Prajwala, and for the trafficking agency, which is an NGO organization. I would like to call upon Dr. Neeraj for the panel discussions. He's a consultant gynecological endoscopic surgeon and obstetrician at Birthright Hospital, Hyderabad. And Dr. Ramakrishna Prasad, sir. He is a former professor and HOD of urology at the Osmania Medical College and consultant urological andrologist and renal transplant surgeon. Dr. Shobha. Yes, she's the president of OGSH and she's a senior consultant at Remedy Hospitals, Hyderabad. Gynecologist. She works at the Dr. Lalita Urogynecological Center, Banjara Hills. And Medicover Hospital. Thank you, sir. I would like to call upon Dr. Vimee Bindra ma'am and Dr. Sanjai sir for moderating the session.
So let's start with the panel discussion. So first case is she's a 29-year-old nullipara female presented with severe dysmenorrhea with a visual analog scores of 10/10. She was also suffering from primary infertility, regular cycles but severe pain during periods, painful defecation and a VAS score of 8/10. No urinary complaints. Imaging on ultrasound showed, as Sanjay sir said, DIE, that is deep infiltrating endometriosis of uterosacral ligaments and focal adenomyosis of outer myometrium. She underwent laparoscopic peritoneal nodule excision, posterior peritonectomy, bilateral uterosacral nodule excision, and focal adenomyosis of outer myometrium was excised. First day post-op, Foley's catheter was removed. She passed flatters, vitals were normal, no abdominal distension. She was tolerating soft diet. Patient could not pass urine and complained of urinary retention after Foley's catheter was removed. What could be the reason and how would you manage her?
This was on day 1.
Yes.
Right. So clearly with that kind of extensive surgery which she had and the uterosacral nodule which she had, it's more likely that her hypogastric nerve probably got damaged, and that's where she's struggling with emptying her bladder.
What got damaged? Sorry?
Inferior hypogastric nerve.
Inferior hypogastric.
Yeah. So that's where I think the problem could be, and I think these things should probably have been explained pre-operatively as well, because with that kind of history and the picture which you showed, these complications or these kind of immediate post-op symptoms, if I may say, should be expected or could have been expected. So the answer is yes, that's probably the likely diagnosis.
Yeah, so the most likely cause is inferior hypogastric nerve. It's basically neuropraxia rather than the transaction of the nerve, and this is a temporary change. So we did an ultrasound on day 1 which showed urinary retention. There was no hemoperitoneum or intra-abdominal collection, because hemoperitoneum can also cause urinary retention. So we ruled out all other causes of urinary retention, and she was recatheterized and started on alphazocin. So this was her surgery video, where we routinely do hysteroscopy, vaginoscopy, and cystoscopy for all DIE patients. In case we missed something on imaging and we can pick it up, we counsel the patients properly. And if we find anything incidentally also, we'll remove it. So this, you can see a lot of peritoneal nodules were also there. She had anterior focal adenomyosis of outer myometrium as well as posterior focal adenomyosis of outer myometrium also. So dissection of posterior peritoneum in most of these cases needs to be done because we lateralize the ureters. And this should be a nerve sparing surgery to avoid complications or the long-term effects of these surgeries. So we always ventro-suspend the uterus. We use a straight needle and it works very well, better than any of the manipulators. You can see the peritoneal nodules on the posterior peritoneum, and we usually start from the sigmoid mobilization. After that, we identify the ureter. We go to the avascular spaces. we all know that the pelvic spaces, there are avascular spaces which helps in our dissection. So you can see the nerves very clearly, and that was the inferior hypogastric nerve. And we usually we do a nerve sparing surgery. We try not to damage them, but then yes, neuropraxia can cause such symptoms. So these avascular spaces are very important for dissection. The medial pararectal space and the lateral pararectal space, which is divided by the ureter. And similarly, we also do ovariopexy because posterior dissection becomes very, very easy if you use these suspensions of the ovaries and the uterus. And similarly, right side, we did the peritoneal dissection, lateralize the ureter, and excise the both uterosacral nodules. And we also do the posterior peritonectomy in a butterfly fashion because the theory of mulariosis or the stem cell theory which are some progenitors which can give rise to endometriosis are removed by that process, and complete reperitonization happens within 48 hours of such surgeries, and there are no risk of adhesions. We have done re-laparoscopy for some of the patients, and posterior peritoneum was very, very good. So this was a big uterosacral nodule. The origin of the ureteric nodule usually starts from the uterosacral nodule or the bowel nodule, and they start extending laterally and engulf the ureter. Dissection of the rectovaginal space is important, and most of these cases we also excise the focal adenomyosis of outer myometrium with a single layer suturing. So this was the final picture for this patient, and this patient presented to us with the urinary retention, and that was self-limiting, and patient did not have any other problems. So surgery for DIE, especially involving the rectovaginal septum and sacrouterine ligaments, is challenging and can lead to postoperative widening dysfunction in 15 to 20% of the patients, possibly requiring intermittent self-catheterization. This complication most likely occurs as a result of damage to inferior hypogastric plexus, as Dr. Neeraj already said that, which contains the parasympathetic pelvic implanting nerves responsible for bladder contraction. So they usually need some kind of drugs which helps in detrusor function as well. Postoperative widening dysfunction is frequent. In most cases, the problem is temporary. And when DIE with an engine classification B is noted, the B, the uterosacral and the parametrial node involvement, and if it is more than 3 centimeter, more risk of voiding dysfunction can be discussed with the patient in the postoperative period so that they don't get panic why I've been catheterized at the time of discharge and I have to keep it for a few days. Systematic and complete nerve sparing, including pelvic splanchnic nerve dissection during surgery for posterior DIE, improves immediate postoperative urinary outcomes, reducing the need for self-catheterization without increasing operative time or complication rates. Postoperatively, patients with DIE become aware of bladder filling later, have a higher bladder capacity and higher maximal flow as well. So there are various studies which have shown that surgery itself does not cause a widening dysfunction. It may be a pre-existing and which was masked by other symptoms also. So meticulous dissection of the anatomic spaces and the careful DIE surgical excision allows to avoid iatrogenic damage to pelvic autonomic innervation and to preserve the sympathetic and parasympathetic roots. DIE surgery does not seem to be the cause of postoperative urinary symptoms, but rather seems to have a beneficial effects on bladder function.
If I may just ask you, Vimee, you just mentioned about posterior peritonectomy. I don't have experience of it having done myself, while I have seen the presentations and I've read about it. You said you've gone in 48 hours and seen that it has been completely
No, I have not gone in 48 hours. I have done re-laparoscopy for some of the patients for ectopic or some other reason,
right,
for which I had done a peritonectomy and the peritoneum was very good.
And it's like absolutely fine.
It's absolutely good. Yeah, absolutely.
Because that's
good.
one thing which I always wondered as to when we are completely making that area raw, will it have any implications which we probably are not aware of now, but it may come up at some point?
No. There is, like I suspended the ovaries. So there are some papers where they say that you leave the suspension for 48 hours so that the ovaries don't get adhered. But initially we were doing that, but then we stopped doing it. And there is no change in the imaging when we are sending them for 1 month or 3-month imaging for follow-ups. So clear periuterine planes can be seen in these patients, and there are no adhesions or periuterine adhesions with the other structures which we find in DI patients, because we compare with the preoperative imaging, and they absolutely have very, very good periuterine planes.
That was my follow-up question. Sorry.
Ectopic was done 48 hours later.
No,
That
no,
means
no.
what you said for ectopic.
No. He asked me 48 hours later you went in and saw. No, I said
some
no.
reason you
For
said
some
ectopic
few months later,
underwent.
I did a ectopic pregnancy for the same patient, and I saw
later.
that.
So I thought in 48.
Few months.
Okay,
No.
okay,
In 48 hours, reperitonization happens.
Anyhow, it happens.
Anyhow, it
Theoretically, we know, though we did not see it. I just want to say one more thing. In these kind of dyes, deep infiltrating endometriosis, so they say even the nerve sparing surgeries and all, however well we do, so they say that on one side we have to be less radical to just preserve everything, the nerve plexus, so that they will be better off. Is it so? Do you do
We
that?
actually wanted to discuss this in one of the cases. So we have one case where we will discuss about it. Basically, it's more important when there is a parametrial nodule. So when bilateral parametrial nodules are there, you have to be less radical on one side, and where the lesion size is smaller. So we rather leave a nodule on one side and completely, because parametrial nodule when you remove, definitely we are going to sacrifice inferior hypogastric nerve, and patient will have some voiding dysfunction. So if we remove both the sides, she will have to self-catheterize. So if we leave one side, she will have at least respite from those symptoms.
But as you said, it's not injury to the. So,
When you do a peritoneectomy also, the same thing happens. I just wanted to tell.
yeah, about the hypogastric plexus injury, as you said, it's just neuropraxia. You are not directly injuring the nerve when you're doing, especially nerve sparing. So, don't you think it's more important in removing the nodule rather than trying to leave it and being less radical? Because the voiding dysfunction we all know is only temporary, because it's only neuropraxia, not direct nerve injury.
We are talking about leaving the nodule if bilateral parametrial involvement is there, not other nodules. We are removing all the nodules. Only parametrial involvement, which happens just above the uterosacrals and medial to the ureter. That nodules, if both the sides are there, then we do that.
But most of the times, this voiding dysfunction is, as you said, self-limiting. Like
Yes,
they
most of
recover on
these-
their own. Yeah.
Yes, even if
you
remove,
just have to put them on catheter for a couple of weeks.
yes, yes.
How do you identify the hypogastric nose on the table?
Sir, I showed the video.
No.
Sir will tell, I think.
So the way to identify is don't dissect the ureter cleanly. Don't dissect it cleanly. Dissect it almost like there is a mesoureter. So if the hypogastric plexus are slightly lateral above the external iliac artery, but where we dissect in the pelvis, they are medial. So they are medial, then they become lateral. So as long as you push the ureter, if you skeletonize the ureter, you will get the hypogastric behind and you will transect it. So almost have it like a shield and then push everything away, which is what you do when you do radical hysterectomies as well.
That is what we used to do, because before the oncology came and specialist, we were doing all the radical surgeries. So when we did that, all this voiding dysfunction also occurred. That point of time also, because we had to put the ureter, and because we had to, the distal ureter, we had to spare. But we had to remove peritoneum.
No. If there is extensive compression, that simple ureterolysis is enough, or the endometriosis tissue has to be removed. Then inadvertently we may injure the hypogastric nose.
So what tends to happen is it will be before the ureter enters the tunnel. That's where you might injure the hypogastric plexus. Whereas where you injure the ureter is when you trace it into the tunnel. Yes. So as long as before the tunnel you make it like a fascia and then push it to the side. And if you think of it, generally the tumor is, the endometrium is sitting on the top of it. It doesn't come from the bottom. So you just keep everything lateral. As long as you keep it lateral, the hypogastric plexus will be behind it. So normally, even when I help with any of the radical hysterectomy, I said don't sling the ureters. If you sling the ureters, you will take it. You will keep on pulling on the ureter and take everything behind it. So just move it like a meso ureter, push it lateral, hypogastric plexus will be preserved there.
That actually helps radical hysterectomy.
Yes.
Not to electrolyte the ureter. Actually, that because it helps segmental blood supply also. There can be avascular.
Yeah, that helps in preserving the ureteric vascularity also and prevents fistula UVF formation.
One of the complications we come across in urology, in bilateral ureteroneo cystostomy, where you are doing extravesical dissection or intravesical, both combined, one of the complications is retention. But we were very close to the ureteric sheath and Waldeyr's layers. We never go into the deep and injure this thing. But still, one of the complications they described, probably go and injure the hypogastric nerves. But here, is it a thermal injury that is a cause or neuroproxia, you think? Yeah. But one side you heard, and what about the other side? Oh, both sides. Right. Nodules will be separated. Another basic principle is, which is we general surgeons follow, never close the peritoneum under tension, because you are doing a peritoneectomy here. There is a defect. So you can't bring them together, approximate. So, yes, it induces fibrosis. So it causes adhesions, bowel adhesions and all that fibrosis. So that is the general surgery principle.
Thank you. So the history has been there for long enough for all of you to note it. So 33-year-old nulliparous woman presenting with chronic pelvic pain, which isn't surprising. And as it is, generally by the time they have come up to any of the tertiary referral care, somebody has had a go at them. Yes. So almost all of them have previously been operated, generally excising an ovarian endometrioma. Same thing happened.
Just to mention, she was operated in a tertiary center.
So that's what was done before. And initially it does look a bit difficult, but once you start dissecting them around, once you have dissected away the tissues that you want to preserve, then you excise whatever is there that is in front of you. So patient did have the normal treatment in the form of LH, so partial excision and then LHRH agonists or GnRH analogs. So once she comes, what are the normal investigations you would like to do? I've already mentioned it before, sir.
Ultrasound abdomen, transvaginal ultrasound are the most basic investigation.
So that seems to do in majority of the cases, but you have to be confident that that person is good enough. It can't be just somebody doing it.
High resolution ultrasound and good sonologist to be able to make out again the recurrence.
Whereas the gold standard is MRI, sir.
MRI scan, again, somebody who can read it because it is already a operated pelvis. Yes? Yes. Because you are almost going blind and you are being led by somebody who has got squint. So that's the reason you want to make sure that the person has told you exactly where it is so that you go searching for it. Quite often, bladder, when it is defined, you see from the inside there is nothing. Outside, it just looks either end. But you just have to blindly follow that. They have seen it, so it is there. So
Already some resection has been done. Your resection?
no, it wasn't. It was just a laparoscopic endometrioma excision.
That is shaving of the extra.
Partial, yes.
Partial cystectomy was done.
No, resection, TUR.
Excision,
Yes.
the shaving of the nodule might have done the peritoneal nodule over the peritoneal portion.
So you are better at describing what is there on the top, NZN1.
So this hashtag NZN means M and U, means it's a combined scoring on MRI and ultrasound. P0 means no peritoneal nodules. OM means missing. She had undergone a salpingo-oophorectomy, but that is left side. /0 means no ovarian cyst on the right side. TM means left tube is missing. T3 on the right side means her ovary is, tube-ovarian relationship is altered and it is adherent to the posterior surface of the uterus, bowel or the uterosacral ligament. A3 means complete obliteration of the POD. B2/2 means left and right side she has a uterosacral nodule which may be around 1 to 3 centimeter on either side. C2 means she has a rectal nodule which is 1 to 3 centimeter in size and she has a bladder nodule. FB means bladder nodule, the distant location. And in that we do not recategorize them into 1, 2, 3.
Location was mentioned, the bladder nodule, where
Just-
exactly look like.
Yes, it was mentioned on the
Bladder
scan.
or the trigonal, retrotrigonal areas.
It was mentioned.
So generally for urologists, it's a frozen pelvis. That's what we tend to say rather than having that many sentences. So you just go in and make it up as you go along. Yes, so that's what was there. And again, this one, you have to again go by what size they have mentioned and you excise it because it does look normal. The infiltration is within the muscle, which you might not be visualizing either on the inside or on this side.
Here, how much should be the normal tissue margin, sir? Is there any, just like in malignancy?
Negative margin, that's it.
No negative margin.
There is no margin. Sorry, sir.
Then how do you identify where do you start your
So either on the inside there would be some abnormality or on the outside there would be some abnormality. Without that, it is very difficult to find it. So you would measure where so you would see where the lesion is on the inside.
Sometimes both.
No, you have to measure it
Better to open
with a scale.
normal area, sir. Normal bladder, vesica, sir.
So you would measure it with a scale. You would, wherever you have pointed out, and then you measure it with a scale and then make your marks.
Now, do you do simultaneous cystoscopy, right?
So yes, at that time, yes. So we would point it from inside with a telescope inside with a light. You dim the lights and then keep marking around, and then you go and do it. Similar to what you would do for a partial cystectomy for adenocarcinoma.
This has been missed in the previous surgery time?
Yes.
Or
Or they partially just did a TUR. They didn't do a partial system. They just did a TUR excision.
Sanjay, when we do open surgery, we palpate
Yeah.
so that we know the normal viable bladder and indurated.
So here we are dependent on the assistant. Robo doesn't have any tactile at all. So we keep on asking the laparoscopic assistant, can you feel any thickness? Can you feel any thickness? Because the robot doesn't feel it.
It is actually, sorry, it's actually more likely that you will find some endometriotic deposits on the UE fold where the lesion is. So it should not be very difficult to identify even by tactile feel or even by the looks, because the peritoneum overlying the area where the bladder nodule is will not be as normal as the non-affected area.
Yes.
So that will be a big clue for you to take it out.
Yes, it's more of to know what extent we have to excise.
Once you open it, then that becomes more clearer.
Yes.
definitely free of imaging.
Basically ultrasound which showed a diabola type of image, like you can see the image here.
So we need a specialist to diagnose this.
And she also had a rectal nodule which I mentioned as C2.
Normally, sonography cannot diagnose.
Yes.
So this was a vaginoscopy and hysteroscopy, then followed by that we did a cystoscopy.
And you would see just a small one there. Oh, that's the other one was this one. Yes.
You can see a clearly endometriotic nodule.
अरे कुछ था क्या? Okay. Yes.
All these cases, how they land up with you, Dr. Vimee?
They come to the clinic generally. I'm joking.
So many complicated cases, all bladders and then all deep infiltrating endometriosis. Okay.
Because I always ask this whenever I meet anyone, how is your referral practice? Am I allowed to say?
Yes.
80% is through Instagram.
Sorry, Insta.
Instagram.
Okay.
Instagram.
It's not Instagram or
Yes.
Facebook. It's basically I create awareness. That's it. I just tell them the right thing and patient approach. Through media, I just create awareness. That's it.
That's good.
So that's why she doesn't get primary. They always come as reoperation ones. Ureteric is always good until it reaches the last 3 to 4 centimeters, and there every millimeter is a bit of a premium. And it generally is just cold cutting.
So you can see the margins and we can cut them like the normal margins.
How much of bladder endometriosis you see in your practice, Dr. Vimee and Sanjay?
Around 10 to 15% among the ones that end up.
See, all the cases which I get in my practice as a urologist is mostly bladder endometriosis who present with low tract symptoms, frequency, urgency, pain, sometimes hematuria, and all my patients had previous cesareans. So this in actually one of the urology forums we had a discussion when I was talking about my experience post-cesarean bladder endometriosis. One urologist was baffled. Actually, he was like under the impression that endometriosis is seen only in nulliparous. Once she had child, endometriosis is not there. But this is iatrogenic endometriosis, where post-cesarean, very...
Basically, it starts from the peritoneal reflections and it grows on its own. But anterior compartment endometriosis, there may be iatrogenic factors, and cesarean is one of the most common cause, which is mentioned in literature
very
as well.
common after cesarean.
I agree with that. Yes.
Scar endometriosis also because of the endometrial transplant.
How do you prevent recurrence after
That's what the lady was saying, that we are only doing an anatomical operation. You can't stop a biological process.
Do you put them on long-term hormones? You put them on
Very much
long-term hormones for how long?
See, after doing the extensive surgery, the best surgery, also long-term suppression is a must. Probably for that previous case also it was not done. And it can be done with lupride, and then it can be done with LNG IUCD that suppresses, long-term
Madam,
for
first
5
patient
years.
was primary infertility
And
patient.
then primary infertility, of course, we are not doing it. And immediately we send her for IVF treatments. For the other cases, long-term suppression does help a lot, even diagnosed for years. So probably for the previous case, had they not, they did not put her on the suppression, that is where probably it grew, or they missed those lesions in the first operation.
They have given letrozole for 6 months, 6 doses of GnRH. They have not removed the disease completely. That is what we want to convey the message.
Yeah, okay.
And I want to just ask, you said you send all the patients for IVF, ma'am? Huh. No, primary infertility patients after DIE excision, spontaneous conception rates are 48.8%. So please, if their AMH is good, tubes are good, allow them to conceive naturally, and our patients have conceived naturally.
Immediately, it is the best because everything is so clear and clean. That is the best.
Ma'am, I won't agree with that.
And then see, I'm
Not
not
for
saying
all
directly
patients.
jump to IVF. You give her some time of 3 months, but don't give her too much of time. That is the message I want to give. Yeah.
So many times, patients who conceive naturally.
You don't do any treatment
don't
also,
have
many
any
conceive also.
symptomatology. Absolutely no symptomatology. For an obstetric indication, you are doing a cesarean section. You find extensive endometriosis. But they conceive without any problem.
Yes.
And immediately also again they will conceive and come back. And you are baffled.
Yes.
Because you see, the endometriosis is so...
It behaves in very different ways. True, ma'am.
Small nodules in the peritoneum, they'll have severe pain. And even with big endometriomas, they may not have any symptoms also. Unless, you are doing a routine scan and you find the endometriomas. That is the enigmatic situation with endometriosis.
It is definitely an enigma, as you said, ma'am. That's true.
So proper preoperative mapping is most important in such cases, and complete excision of disease, because previously she was not, the surgery she underwent, the complete excision was not done for her. And the same question we have been discussing, would you do a cystoscopic resection? The question is to urologist now. Now, such a big nodule, would you do a cystoscopic resection? Not to Dr. Sanjay.
No,
No, you
laparoscopy.
patient presented to you with dysuria and you did a cystoscopy. You do not know she has endometriosis. Now you found this. Would you do a cystoscopic resection?
No, no,
First of all, we will be
laparoscopic
doing a
resection.
staging, whether it is infiltrating the detrusor, and that is one. If it is infiltrating the detrusor, definitely it requires a partial cystectomy. Suppose a nodule, superficial nodule confined to the mucosa or submucosa, situated in the dome, then probably we can resect. So, because there are difficult portions in the bladder where it is hazardous to resect, in such situations you have to do a resection. I mean,
If
partial
there is such a
cystectomy.
big submucosal nodule, it has to come from the external surface. So if you resect it transureterally, you're doing an incomplete resection.
So, twice resected, again recurrence, we had a partial cystectomy.
So it doesn't, because the origin is from the peritoneal surface
Outside.
coming in, unless the, yes, outside. Yes. So you would do a biopsy to make sure that they don't have malignancy. Yes.
So, but once you have seen one bladder endometriosis, you don't need, for my first case, I have done a biopsy, but later you would recognize it as soon as you do a cystoscopy. No, not just me. Not just me. Ask any urologist. You see very typical blue dome cyst, you don't need to take a biopsy. You will know that it is endometriosis.
Biopsy, because sometimes patients won't accept directly for partial cystectomy unless we convince them with the biopsy.
Yeah, so I have a question for the bladder symptoms. The patient goes to urologist, and so they do cystoscopy, and like these kind, it must be from outside the peritoneum, and they don't see it. And so, is it prudent to add laparoscopy also to it? But sometimes it gets missed.
No, it isn't the question of just diagnosing. I wouldn't just do a diagnostic laparoscopy. If I know that that's
therapeutic also.
How many of us are skilled enough to be saying that I will excise it completely? So she needs the imaging to make sure that there isn't anything else, and then go prepared for it and say, I've got the next 6 hours to resect all of it completely. There's no point in just going and doing a bit of it. Either we go in to do excise all or nothing.
Yes. Always multidisciplinary.
Yes.
That is what
No,
he said.
laparoscope, so it,
Yes, sir.
you should have done a mapping before.
But it missed. We don't
No,
know.
sir, mapping with the imaging.
Yeah.
I think if you have posted the patient only for cystoscopy, abandon the cystoscopy if you suspect endometriosis, get a proper imaging done, rule out the bowel disease and other disease, involve a colorectal surgeon, an endometriosis surgeon and a urosurgeon, and then plan her surgery.
In isolation.
Yes, most of the cases it doesn't.
In post-cesarean, it could be in isolation.
So it's not only endometriosis.
Which is the best?
Only not bladder. There is other places.
Which is the best investigation to know the extent of the disease? Is the MRI or to the laparoscopy?
Very good ultrasound scan would be a good start.
Equally good. Equally good. Not better. Yes, depends on coincidence.
So this patient, if you have watched, if you could watch the video in this cystoscopy, we could not find the nodule actually. But we knew where the nodule is. So under cystoscopic guidance, we marked the nodule robotically and then we excised it. So these were the markings we made under the cystoscopic guidance because we knew almost the location of the disease and we could excise it completely.
Patient by pre-op imaging?
Yes.
Yes.
So we kept on looking for it and we could just see one blue dot. And then we knew that there was about 3 centimeters on either side. That's why we marked it cystoscopically and resected.
We'll quickly take you to 2 more cases.
Okay. So 28-year-old who all the slides were done by disclaimer by Dr. Vimee Bindra. So that's why I don't have control on the content. Had a 8 centimeter left-sided endometrioma. Ma'am, You can take it. What would be the investigation? You didn't see the first slide? This is what it is, the first slide. Gynecologist.
Left-sided endometrioma, and she's planning to
Conceive.
Okay.
We need to have some markers, serum markers, to confirm, at least, rule out other ovarian malignancy.
The one thing is, you are saying endometrioma ultrasound. Like you said, we have to map it. Is it only a ovarian endometrioma?
Yes. And also ultrasound of the abdomen to screen the kidneys. Yeah.
Other than imaging, anything else? So ultrasound scan to look at the upper tract as well as the pelvis and map it.
Also, but to know the ovarian reserve, but even AMH, we are not really sure the lab.
It is not only for junior consultant, but also for a medical.
Yeah. Okay. So these were done.
Preoperative enzyme mapping and evaluation of ureters and
It's a
kidneys.
very non-specific investigation. Yes.
It's just that it was an ovarian mass, so we just wanted to be sure.
So this was an imaging where,
But not in the oncology numbers. It will be slightly elevated because there's an peritoneal problem.
I think role of CA125 in endometrioma is really waste because it's not going to help you diagnostically. It doesn't help you diagnose it. Because it can be raised in UTIs, it can be raised in given blood in menstruation, it can be raised in anything, inflammation. So what's the point in having it when it's not going to change your management?
No, we wanted to rule out ovarian malignancy.
no, highly elevated levels are a marker of malignancy. So we had patients where it was 3,500 or 4,000. In those patients, it helps.
In those patients, there are other symptoms as well which do not miss on.
No. We had patients coming to us for endometriosis surgery. And then we found that, and on MRI, we could see the features. Aorta classification was done on imaging and all that, and we found out that it was malignancy. It was around 3,000, 3,500.
Anything above 200 during reproductive age is suspicious.
With that kind of endometrioma.
Yes, postmenopausal it is above 35, but during reproductive age it is above 200.
With that kind of endometrioma, many people have what?
No, we have not.
No, with endometriosis and adenomyosis, I have seen 400, 500 also as a very normal levels, like benign. Especially when they have adenomyosis. The levels shoot up drastically, but I have never seen above 600, 700 as this thing. Usually up to 500. No, if we are confident in endometriosis, I don't think we need. We don't need other markers.
Yeah.
I would really not get that deep into the oncology.
Okay, let's proceed.
So this was the endometrioma, and there was a concomitant right uterosacral nodule. There was a left uterosacral nodule also, which we found during surgery, and right hydroureter nephrosis was there. So this was her vaginoscopy, where you can see a bluish nodule on the right side, and this was a laparoscopic picture where big endometrioma was there, and this is the right hydroureter. As I said, we usually use uterine ventrosuspension, and cystectomy was done. Now there are various treatment options have come where sclerotherapy can be done for big cyst if patients want to conceive and all those things to preserve the ovarian reserve. In this case, the right ovary was absolutely normal, so we decided to do the cystectomy and uterosacral nodule excision. So bilateral ureterolysis was done in this case, and stenting of the ureter was tried, but we could not negotiate because of the stricture of the nodule. So ureteric catheter was tried, and after removing a bit of nodule, we again tried with the ureteroscopy also. We could not negotiate. The ureter was impinging so hard on the ureter. If you had seen that image, there was a constriction ring on the ureter as well. So we could not go inside that as well. But then we successfully removed the nodule and the ureter was normal. DTPA renal scan was done pre-surgery. Residual renal function was good, so we decided to preserve the kidney and the ureter. And we did not have to do the ureteric neocystostomy. This was the ureteroscopy, which also we could not negotiate. And this was a nodule going up to the vagina, as I showed into the vaginal nodule. And this was completely excised and it was sutured. And the good news is that the patient has conceived, patient has delivered also. And she was from Ireland and she's coming back to us this month for the follow-up.
So after excising the nodule, could you again stent or scope the ureter?
We keep
No,
the
it was
stent
not
for,
required.
depending on the patient's ureteric.
No. This particular case, after excising the nodule, initially before excising the nodule, you couldn't negotiate the strictured area or the compressed area. So after excising the nodule, did you put a stent again? I wanted to know.
Yeah.
Not for this one, but normally what we do, almost a laparoscopic guidance of it. It tends to go into a cul-de-sac. We laparoscopically guided and we were able to manage to stent. For this lady, we could not manage stenting. Yes, and by the time we were almost 5 to 6 hours into the overall operation. So we just said, if required, we'll do a nephrostomy. Thankfully, she wasn't symptomatic with it. She started draining and she
But
was
how
fine.
do you make sure that the ureter is not injured during your surgery? How do you
We
make
could just,
sure
we
that
did a retrograde on the
Yeah,
table.
yeah.
Nothing was going beyond. Nothing was going beyond just because of the kink that was there. So the only thing would have been to excise it and then put a ureteric into
Yes.
ureterocystostomy.
After excising
Yes.
the nodule, we could have stented it again if
Yes.
there is no obstruction.
Yes. In that post-operatively, she started draining and there wasn't that much of an obstruction. So we were lucky in that one. But could we manage stenting? We just could not. It just kept on going into a cul-de-sac. Easiest would have been, as I said, just doing a ureteric reimplantation. But we didn't do that on that lady.
Yes. So this is again our data from patients with endometriomas who had deep lesions. So almost all of them had deep lesions of either the uterosacral nodules or the bowel nodule was involved. So always look for other lesions when you are dealing with an endometrioma patient. So endometriomas never occur alone. Preoperative mapping is important. Always ask for kidney and ureter imaging as well. And only stenting the ureter does not help. We have received patients where they found hydroureter. They didn't know endometriosis is there. Stenting was done and then patients were told to just follow up. Endometriosis may be silent and progressive, resulting in kidney loss. Finding a cause for hydroureter is important. Always seek endometriosis expert opinion for their management. Hydroureter. So this is a case of 29-year-old. She was a lactating mother, delivered 7 months back. She presented with complaints of dull pain in the left lower abdomen and flank for 2 to 3 months, regular cycles with no dysmenorrhea. She had history of endometriosis surgery twice before her pregnancy. So what are you suspecting? What is the differential diagnosis and what investigations you would order for her and plan for her management?
First thing, we would do an ultrasound for the kidneys. Yeah, we need to rule out could be because of the previous surgical complication or recurrence of the disease. There could be ureteric entrapment.
So ultrasound was done and in which we found the uterus was pushed to the right with retroflex fundus and features of sequelae of deep pelvic endometriosis involving the posterior compartment. And there was a ureteral lesion. There was a lesion impinging onto the ureter. It was a retrocervical cystic area which was covering the ureter completely and there was a hydroureter. And you can see that cystic area which was compressing the ureter there. And this was her surgery which we managed robotically. So this was the initial picture. As I said, we always start with the sigmoid mobilization followed by the uretrolysis. And here you will see that cystic area, some chocolate material coming out also. So this cystic area with the uterosacral nodule was compressing on the ureter, and usually these cases are silent. She was a lactating mother and not even getting her periods, but she had a dull pain in the flanks for last 2 to 3 months and she reported to us. And because she had 2 previous endometriosis surgeries, we suspected that it could be a ureteral involvement.
But isn't it so unlikely that just after a pregnancy that it has relapsed?
Madam, that is what is the importance of the complete surgeries. So previous endometriosis surgeries, maybe they were not complete. They never evaluated the ureter. So it was already there. Now over the time, progression might have happened.
Normally, you don't expect endometriosis to recur
Yes, that's what. During pregnancy
Yeah.
and
So
during
it is an existing disease which was not addressed.
Residual disease. Usually it's very progressed or whatever.
Somebody asked a question.
So why not medical management? Why do you have that risk of surgery?
These, if it is a hydroureteronephrosis, kidney is also involved. Kidney was dilated. She will lose the kidney if the residual renal function is less than 10%. So these cases are contraindicated for medical management. So this was a big nodule which was impinging onto the ureter. And this case had a concomitant parametrial nodule also. That is what we wanted to discuss, that if you have bilateral parametrial nodule, one smaller nodule can be left and remove the bigger one. Now you can see the ureter has come back to the normal shape and size. And we also use the ICG to check for the integrity of vascularity and all. This is my team, Dr. Sanjai. I would like to thank him. He is my mentor as well for robotic surgeries. And he used to come to my theater every day and used to tell me, why can't you learn robotic at this age? And I can do it at my age, like you are too young, do it, do it. For last 2 years, he was pushing me. And one fine day, I went for robotic surgery and he mentored me for the cases. And now we are doing a lot of robotic surgeries with the team management. Our colorectal surgeon is also sitting there, Dr. Kishore Alapati. He doesn't want to come in front. I don't know why. Because we can't manage posterior anterior compartment disease without these people. So we are the middle compartment, he's the posterior and he's the anterior compartment. Yes, we are doing segmental resections, we are doing shaving, discoid excision. Yeah, I showed one discoid excision in one of the, this thing. And I would like to thank HUS and EFI and Apollo hospitals for doing this event and bringing more awareness for such disease. And thank you, panelists. Thank you, Balamba ma'am. Thank you, Murthy sir. And it was a pleasure to have all of you here. And Dr. Sanjay would say a few words.
I think there isn't any age group for learning, and that's the reason I was honest in saying that what was my impression of things prior to 2018, and probably I should have said what was my impression last week and what is my impression. The more you learn, the more you realize that actually you don't know much. Thank you very much for learning in the process along with us. Thank you.
I also have two more gynecologists in my team I want to introduce, Dr. Archana Reddy and Dr. Shweta Reddy. They are a very crucial part of our team. So without them, we can't manage such difficult cases. Can we have one group photograph?
Thank you for the opportunity, and it's a good learning experience for us too.
Thank you, ma'am.
It's a visual feast, Dr. Vimee. So many cases. It's really good, actually. You know.
Thank you so much, ma'am. We also are. No, I was so happy with laparoscopy. I used to say, but I used to say I can do everything laparoscopically. Why should I do robotics? So that was the hesitant. Like I was hesitant to do something. Age, I was saying, yes, I can do something new. But now I love robotics actually.
morning. Take it.
Ravi Kumar.
Jayaram, sir.
Jayaram.
You're the one who won.
He always keeps me my letter. Come on. Murthy.
तो ये फोटो में ये वाली फोटो में किसको समझ में आएगा कौन किसको दे रहा है?
Why is it all girls are on one side, ladies on one side, and men are on one side?
Not like that. Then I should be on the other side. It's not that.
Skills.
Privilege to stand here. Okay, thank you so much.
idea of